Welcome to the CMEssentials podcast, covering current topics in clinical medicine. The show helps clinicians stay up to date on the current standards of care and catch up with the latest clinical developments and trends. Each episode features a lively discussion between the physician host and a noted clinical expert. They dig into the issues practitioners face every day and provide insight on improving patient care.
Hello, and welcome to another installment of Oak Stone's CME Essentials in Hospital Medicine. I'm your host, Dr. Danielle Verghese. For the past 2 years, I've been working as a hospitalist and assistant professor of clinical medicine in North Philadelphia. My next chapter will take me out to the suburbs, where I look forward to continued service on both teaching and non-teaching teams. This is my first time hosting CME Essentials, and I'm looking forward to participating as we dive into a topic that's pervasive for most hospitalists: non-ST elevation myocardial infarction, or NSTEMI. I'm pleased to be joined by Dr. Marc Cohen, who is the chairman of the Department of Medicine at Newark Beth Israel Medical Center and the former chief of the Division of Cardiology there. He's also a professor of medicine at Rutgers, New Jersey Medical School. Dr. Cohen, welcome.
Thank you very much for this opportunity to talk about my favorite subject, cardiology.
We're happy to have you. Our discussion is presented in 2 parts. In part 1, we will discuss the assays used to diagnose myocardial injury, as well as the subsets of myocardial injury, including our topic of interest for today, NSTEMI. We'll provide a brief overview of the types of NSTEMI with a focus on the pathophysiology underlying types 1 and 2 NSTEMI. We'll end part 1 by discussing the history and workup involved in assessing NSTEMI. In part 2, we will apply this foundational knowledge to clinical scenarios and discuss best practices for hospitalists, as well as treatment options. We will end each episode with key takeaways. Let's begin by setting the stage for our discussion. NSTEMI is a ubiquitous diagnosis in hospital medicine, sometimes taking center stage for a patient's hospital admission, and other times trailing downstream of a patient's primary problem. Since coronary artery disease is a leading cause of death worldwide, it's essential that we hospitalists appreciate where NSTEMI lies under the umbrella of myocardial injury. So let's take some time to dig into key terms we'll be using throughout this episode. Dr. Cohen, can you review troponins and how they help us diagnose myocardial injury?
So I think this is a very good place to start because troponin is like the canary in the coal mine. When you have cell death, when you have myocardial injury to the point that the cardiac cell dies, it then releases troponin, which leaks into the circulation, and we, whether in the emergency room or on the wards, we measure that increase. We now have incredibly sensitive assays for troponin. I don't want to suggest that if you sneeze, your troponin goes up, but you have to appreciate that any kind of even minor injury to the heart, if it results in, 10 cells or 100 cells dying, more and more we are able to hear that signal. It does not need to be some huge heart attack for the troponin to go up. So first and foremost, myocardial injury, we are able to measure it, but we are able to measure it in such a sensitive manner that we now have to spend a little extra time dissecting what is it that caused the injury. Was it a heart attack in the classic sense? Was it an occluded coronary artery? Or was it a fireman climbing up 10 flights of stairs to save a family in a burning building? He or she fire person probably has great coronary arteries because they pass their physical, they run, they jog 5 miles every day. But in the setting of that extreme stress, the demand on the heart outstripped a normal blood supply, what we call a type 2 STEMI or type 2 NSTEMI.
I'm so glad you mentioned heart attacks in the classic sense, because that's usually where our mind goes when we see an elevated troponin, or at least traditionally, that's where the mind goes. And that actually takes us to our next key term for this discussion. We see myocardial injury, and we know that that's linked to an elevated troponin, specifically any troponin elevated above the 99th percentile of the upper reference limit. But how does that relate to acute coronary syndrome and our topic of discussion today, NSTEMI?
So I think it's important to appreciate that cell death in the heart can come from different causes. The most worrisome cause for us in medicine, hospital medicine, as well as in cardiology, is a sudden acute occlusion or near occlusion of a coronary artery. Why is that the most important cause? Because if we take that person to the cath lab, in literally minutes of time, we can reopen that occlusion and, in a sense, just stop the heart attack occurring in its tracks. However, we need to appreciate the fact, like I mentioned a minute ago, that fireman or firewoman who climbs up 10 flights of stairs in a big rush in a burning building where the oxygen level is low, or, for instance, someone who has sepsis and the strain that sepsis puts on the body just causes the heart to have to work overtime, and the heart can peter out a little bit. Even though it's getting plenty of oxygen and blood, there may be some myocardial injury. So acute coronary syndrome is the classic model where you have a blocked coronary artery. But a lot of the NSTEMIs that we see day in and day out, either in hospital medicine or in the ED or in cardiology, that myocardial injury does not necessarily come from an acute coronary syndrome with a ruptured plaque and an occluded artery.
Okay, thank you so much for mapping that out for us. So just for my own recapping here, I'm going to say that acute coronary syndrome is exactly what you referred to when you said that there's an interruption of blood flow to the heart in a sudden manner. Classically, in medical school, we learned that was subdivided based off of elevated troponins, as in an NSTEMI, or if you additionally have an ST elevation, that's what defines an ST elevation MI. Now, you also referred to different pathophysiologies underlying these kinds of scenarios in which we get elevated troponins. And I know you personally have actually written quite a lot on the different types of myocardial infarctions out there, and they can provide a kind of pathophysiologic framework by which we can divide these types of elevated troponin pathology. So would you mind reviewing the types of MI and breaking them down based off of just a brief description of their pathophysiologies?
So the type 1 is the classic one where we have a blockage in the blood flow, most often a plaque that has ruptured and literally interfered with the flow of blood. Type 2 MI is the kind of MI that I described where there is too much demand, and even a normal blood flow can't keep up with the demand. Then you have sudden death, which is given a type 3 designation. And then you have these small amounts of myocardial injury that are almost impossible to avoid that occur in the setting of open heart surgery or in the setting of percutaneous coronary interventions. So where you might have the patient going on bypass, and during the time they're on cardiopulmonary bypass, the heart isn't getting any blood or oxygen. And so there might be small leaks of troponin. But just to go back for a second, if I may, Dr. Verghese, to the acute coronary syndrome. Today, we have a lot of tools that are available to us to help discriminate between a stress type 2 NSTEMI and an acute coronary syndrome. The key element in acute coronary syndrome is that it's usually one artery which is blocked. That one artery feeds one part or one segment of the heart. And so you as hospital medicine people or your colleagues in the emergency medicine realm, you now have point of care ultrasound. We are now very, very comfortable, almost routinely, taking advantage of point of care ultrasound to answer the following question. Is this troponin elevation, which signifies myocardial injury, is it segmental in its nature? Is it just a part of the heart that we recognize is fed by a certain artery, like the anterior artery or the right coronary artery or the posterior circumflex artery? Or on the other hand, in a patient who's septic, do you see a hyperdynamic heart or a heart that has mild global right, as opposed to segmental weakness, suggesting that it isn't just an artery that's occluded, but it's some kind of systemic process that's burdening the heart.
A really important distinction, because you're right, we so often find ourselves trying to answer that question, is this something that's happening within a specific coronary artery, or are we seeing a troponin that's elevated as a reflection of systemic stress on the heart? So this episode will definitely focus on the distinction between those two types of NSTEMI. Just as a quick recap, our type 1 NSTEMI is caused by an acute atherothrombotic event, while type 2 NSTEMI is caused by a mismatch between myocardial oxygen supply and demand, somewhat like that fireman story that you were sharing with us. So now that we have a better handle on the definitions and pathophysiology at play, let's take this discussion to a clinical context. I think most hospitalists can recall a time when they came across a troubling troponin. Our patients can present with several non-specific acute concerns and a number of comorbidities, and our workup often turns up an elevated troponin level. At that point, we're challenged to figure out the etiology of that troponin elevation, just like Dr. Cohen and I have been parsing through. And accordingly, the etiology of that elevation will guide our management plan. So, Dr. Cohen, when we're encountering our patients for the first time, what should we try and find out about their symptoms to better guide our assessment of their NSTEMI?
Your job as hospitalists is to always try to have a handle on the big picture. So, for example, somebody with a pulmonary embolism could have a positive troponin, and that troponin could come from the fact that an acute submassive pulmonary embolism puts a huge strain, demand on the right ventricle, not the left ventricle. And so some of the right ventricle muscle cells can die from that extreme strain. So your job, first and foremost, is to keep an eye on the big picture. Don't just be railroaded into saying, oh, the troponin is elevated, I'm going to call a cardiologist. You don't have to do that right away. Or I'm going to, call the cath lab. Look at certain things. So number one, are there other major issues this patient is facing? So for example, pyelonephritis on the verge of urosepsis, right? Or some kid who's vaping who decides to develop ARDS and is hypoxic and his heart is under a lot of stress. Keep a broad perspective on this. The history is very helpful because most of the time when there's an acute coronary syndrome as the culprit, then there are most of the time more classic symptoms, chest discomfort, chest pressure, chest tightness, or shortness of breath. As a pro tip that I'd love to share with all of you, having done cardiology for 42 years, is never ask the patient if they're having chest pain. Ask them if they're having chest discomfort, because nobody's going to answer in the affirmative, yeah, I'm having pain, and, risk looking like a wimp to you. But if you say, are you feeling a tightness? Are you feeling a squeezing? Are you feeling a pressure? For some reason, those words sink in a lot deeper than when you come to the patient and attack them and say, tell me about your chest pain on a scale of 1 to 10, and you kind of push on them. Get away from the word pain and hang on to the word discomfort. That way the patient feels at ease to try to literally describe it to you. Most of the time when there's an acute coronary syndrome, the patient will describe something to you, either epigastric discomfort or a feeling of pressure or feeling of tightness. And then remember, as I told you, to be open-minded and see if there are any other things going on in this patient that could pose a very imposing burden on the heart, like sepsis, pulmonary embolism, profound sudden GI bleeding, with the hemoglobin down to 6. That's a big imposition on somebody's heart.
Yeah, I 100% agree with you. I've never had anybody walk in and tell me they have chest pain when in fact they have an underlying heart condition. But if you leave it somewhat open-ended and say, are you experiencing any chest discomfort? You find that suddenly there are more takers, and patients might find that, oh, you know what? That description might in fact include what I'm experiencing. So it's important framework to have in our heads that it may not just be that chest pain that you see on TV. And just to put some definitions to this while we're at it, angina, we classically learned as that retro or substernal chest pain brought on by exertion, relieved with rest and or nitroglycerin. But that is a more traditional way of thinking about it. And now we have expanded our line of questioning to include other symptoms, including just starting out broadly with chest discomfort. You mentioned shortness of breath, dizziness, lightheadedness, nausea, vomiting, syncope. All of those might be warning signs that the heart's involved. We've also talked about how that discomfort may not necessarily be located in the chest. So people can report it in a range of areas, not just shoulders, arms, neck, back, upper abdomen, jaw. So it's always important to try and keep that open mind. And like you said, while keeping an eye on the big picture of what is really going on with the patient outside of just that elevated troponin. So with that being said, are there other symptoms that patients might describe besides the ones that we've mentioned already that might raise our concern for type 1 versus type 2 NSTEMI, or maybe just qualifiers that patients might have?
If I may interrupt for a second, I'd like you to include and share with your colleagues diaphoresis.
Yes.
Now, obviously, if they have a temperature of 104 because they're septic and have pyelonephritis, they might be sweating a little bit. But if that's not the case, when a patient presents to you with vague complaints and they're diaphoretic, you got to really look at them very, very carefully. And I'll never forget a patient that I had who was a diabetic. And you know how diabetics are notorious for not having classic symptoms. The guy literally, he said to me, "I don't feel right." And when I very gently and courteously said, "Well, what do you mean?" He said, "Doc, I don't feel right." That was the end of the history. And then I looked up and I saw that he had beads of sweat on his forehead. And I said to the nurse, "Get the cardiogram machine right away." And he was having a big anterior wall MI, a big acute coronary syndrome, based on my worry that diaphoresis meant that he was in a world of hurt.
That clinician intuition is so essential because I think those are the cases that keep us all up at night. What if I walk in and a patient doesn't give me very much by way of history? How do I know whether or not they're experiencing something more serious under the surface? I remember, especially in my earlier days out on the wards, I was a little intimidated by that prospect, but I realized actually in practice, you just got to rely on your gut. If you walk into the room and you see somebody, don't forget that general exam. So if the patient's in distress, and one of the best markers I found is, do they look unwell? And diaphoresis is huge. If somebody's got those beads of sweat, then your alarm bell should be going off and you really should be thinking that something important is happening here. Other things that sometimes get my alarm bells ringing is if the patient tells me that they're not heart-specific symptom, let's say their nausea comes along very predictably with exertion. And I always try to remember it's not just that physical exertion, but also the emotional exertion that can sometimes be sneaky. Particularly where I practice, people don't necessarily have the opportunity to go outdoors and exert themselves often just for safety reasons. But there are plenty of other scenarios that can play a little stress test on our hearts, including emotional exertion. So I try to factor that in. And then also just the progression of their symptoms. Have things become more frequent? Is that discomfort that they're experiencing more lasting? And is it also lasting greater than 20 minutes? I've heard has also been used as a cutoff.
Let me just dovetail for a quick minute before you transition. You mentioned the word progression. Give the patient the opportunity to look back and say, okay, you're now having, a lot of discomfort in the chest area now, but take a breath and take a minute and think back. Were you feeling anything a week ago? Were you feeling anything 3 days ago? More often than not, the patient, a light bulb will go on in their head and they'll say, oh, when I was jogging, towards the end of the jog, so I stopped jogging and I just went on the treadmill. And then on the treadmill, in the last 2 days, within literally 5 minutes, I felt a little something. By giving the patients the opportunity to think back a little bit, you may come across another classic symptom for the acute coronary syndrome, which is what I call stuttering, waxing and waning symptoms. Like you mentioned the word progression.
No, we really don't talk about that stuttering all that often, so I'm glad you brought it up. And then honestly, we always are here for tips on how to jog a patient's memory, because sometimes you get more history than you want, and oftentimes you get less history than you need. So always happy to dig into some more questions around symptoms. But I feel like we can now say that we've covered a good number of ways to find out more about our patient's symptoms alone. But let's dig into our diagnostic tools. Earlier, you mentioned EKG and some bedside echoes. Can you tell us a little bit more about these tools that we have at our disposal to work up our patient's presentation?
The ECG, obviously, first and foremost, from a quality point of view, you need to get one quickly. Now, it is not very specific, other than when you see rip-roaring ST segment elevation or very profound ST segment depression. But make sure that you get it quickly. In retrospect, if you miss a diagnosis of an acute coronary syndrome, somebody who's reviewing the case is going to hound you like, how long did it take before you did the cardiogram? But having said get the cardiogram quickly, the cardiogram very often isn't all that helpful from the specific point of view. T-wave changes by themselves don't really motivate me as a cardiologist to go crazy. What makes me crazy is if I see ST segment depression or obviously ST segment elevation. Now, in the world that you practice in and in the world that I practice in, many of our patients have high blood pressure, and so they have left ventricular hypertrophy, and they may have some degree of ST depression just as a baseline. Very important for you as hospitalists to document, I do or I don't have a baseline for comparison so that you can sound like you did your job. I have this cardiogram, I looked at the old one, these were the changes, and therefore I'm thinking X, Y, and Z. That's critical. However, I would like to highlight that if ever you're insecure and you see changes on an electrocardiogram and you're harboring concern about this patient having an acute coronary syndrome, just call your pal in cardiology and get an echo. That is the most specific way to unmask a segmental wall motion abnormality, or frankly, another problem. Maybe the chest pain is pericarditis and you'll see a pericardial effusion, right? Or as we mentioned, maybe the chest pain is from a pulmonary embolism and you'll see a markedly dilated right ventricle. That echo to me is good practice in 2024. Everybody now is learning how to do point of care stuff. During regular business hours, there's always some tech who's ready to come down to your ward and help you out. The cardiology fellows should come and help you out. Even if you're in a jam, call the emergency department and have the attending run up for 5 minutes and slap a point of care ultrasound, because now they're very qualified to do that.
Yeah, I mean, definitely pros and cons to each diagnostic modality. EKGs, especially as a hospitalist, are so accessible. I can ask our bedside nurse to whip up an EKG for us real quick. On the other hand, the bedside TTE, or even a formal one, if we can get a hold of one, so informative and contains a wealth of information, or might just show us what else might be going on. Just to dig into the EKG findings quickly. So you mentioned ST elevations, ST depressions, and of course the locations of those changes can certainly tell us a lot about whether or not we're dealing with, for example, pericarditis or something more regional, as you mentioned earlier when defining acute coronary syndrome. Also, just wanted to take a quick moment to mention Q waves, since those are kind of the hints that we can get once in a while just to speak to a patient's prior history of MI, where we don't necessarily always get that information from the patient at the start. And you mentioned T-wave inversions can be neither here nor there. We can note them if we have the benefit of a prior EKG, but it's hard to discern exactly what that means for the patient.
I would like to share something. In the old days, Q waves, we felt were really definitive and diagnostic. Unfortunately, now, because of obesity, when the patient is lying down and their abdomen, pushes their diaphragm all the way up into their lungs, and the heart is sitting on the diaphragm, a lot of times you see Q waves that don't actually mean what you and I, learned in school, what Q wave meant. So you have to be a little careful. And that's again why I don't dilly-dally. I just try to get help from the echocardiogram to really document whether the electrocardiogram abnormality is for real.
This is some real-time myth busting. I think it's hard to refocus the training that we've had about Q waves, as you mentioned, or even EKGs, and really do start to see what you mean about how EKGs can be there and helpful if they should show something, but otherwise might be a little bit non-specific and hard to apply in a real-time fashion. So very important distinctions. Of course, I would be remiss if I didn't mention the focus of today's topic, which is our serologic workup. And that takes us right to troponin. So you touched on this earlier, a lot of us have trained on earlier versions of the troponin assay, which was a little less sensitive. But these days, we're increasingly incorporating the use of the high sensitivity troponin. So now we're on a 5th generation assay. Can you tell us a little bit more about your pros and cons of these high sensitivity troponins?
First of all, the pros and cons are going to become very less relevant because all labs are going to slowly abandon all the older assays and pick up on the very high sensitivity assays. In fact, our hospital doesn't even waste time anymore doing CPK. I have separation anxiety from when I was a young doctor, relying on serial CPK measurements. And now, poof, I can't even order one if I wanted to. But the bottom line is that there is evolution in the sensitivity of the troponin assay. And, all of us can just cop an attitude and say, oh, this is ridiculous. They're overly sensitive. They're going to force me to call and label this patient as a non-STEMI. But it actually makes you think a little bit, because if you have two people who are on dialysis and one of them has a low but abnormal elevation in troponin, and the other dialysis patient has a normal within range troponin level, I assure you that the patient with the abnormal troponin, as low as it is, but still abnormal, has a worse prognosis. So even though these assays now are crazy sensitive and maybe driving us a little bit crazy, they do help us identify something bad happening to the heart, not necessarily a catastrophic heart attack, acute coronary syndrome, but this like low grade grinding of our heart cells, whether it be dialysis or chronic hypertension, even heart failure, right? And so these high sensitivity assays are valuable, not necessarily so valuable in the sense that everyone who has it needs to be ruled out for an ACS, but valuable when you put it in perspective of the greater context of the patient. Now, just a couple of quick tips about that. If you're concerned about an acute coronary syndrome, I wait no more than 1 hour to repeat the troponin, because if you're having a classic heart attack with an acute occlusion or even an almost occlusion of a coronary artery, that first troponin could even be normal. The second one within 1 hour will go up, and the third one within the second hour will absolutely go up. When I'm consulted by a hospitalist who says, I was concerned and I repeated the troponins, and I look at the timestamps, and the hospitalist sat on the patient waiting every 3 hours for a repeat troponin. And now you're calling me at hour 6, when the third troponin went very high, when you could have done troponins every hour. I'm not saying you do 1,000,000 of them. I'm just saying you do 2 or 3 of them every hour. You can jump the gun and get on top of that patient quickly and effectively. I feel terrible because there's still a lot of people out there who just write these standard orders, serial troponins Q3H, or God forbid now Q6H. Who wants to wait around 6 hours to repeat the troponin? That's like silly almost. So yes, the high sensitivity troponins pose a challenge to us in terms of interpreting them, but I think that they are valuable to help us discriminate patients that are heading into trouble versus patients who are less likely to head into trouble.
A lot of important points that you brought out in this discussion alone, because yes, there's definitely some of those elevated troponins that I've been frustrated by because, like you said, looking big picture, my patient doesn't seem to be having an acute cardiac event going on, but the troponin's elevated. But it's really important to know that that finding is still of tremendous value because it may speak to what's smoldering beneath the surface and overall might suggest that this patient is sicker than somebody who, say, did not have an elevated troponin despite the same presentation. So it still should speak a little bit to the patient that we're working with and what's going on there underneath the surface. And I'm so glad you touched on how do we use these new troponins, because that's a huge question as well. I know for sure myself and other hospitalists have found ourselves trying to find, okay, I know in training on the lower sensitivity troponins, we did space out our serial troponins every 6 hours. But now with this high sensitivity troponin, it's really important to note that you don't need to wait as long as you once did on the low sensitivity troponins. You can repeat that test, as you said, every 1 hour. I've seen a few places saying also 2 to 3 hours, but just don't wait. I'm so glad you also reminded us again, just use your clinical intuition. If you think that the patient is here with a cardiac concern and that initial troponin isn't elevated, then don't say, okay, all is well, and this one test alone can put my mind at ease. No matter how high sensitivity it is, it's just a snapshot. So perhaps repeating that test in another hour to fit within the bigger picture of, okay, something is going on with this patient's heart. I just need to paint myself a better picture of that.
Exactly. I'm re-emphasizing everything you said. I appreciate it.
Well, I'm going to put you to a little bit more work here. So let's say we start out with a patient with whom we're concerned. We think that they have some kind of acute process going on. For example, that diabetic you mentioned earlier who says, Doc, I don't feel good, and you don't know much else. You get that initial troponin and it's elevated. How often should we trend to try and see what's going on with that patient? And let's say we're in a scenario where that patient is experiencing a non-cardiac event. Let's say they're here with a pulmonary embolism or something that isn't specific to the coronaries. Where do we take those troponins to? I've heard trend to peak. Does that still apply with the high sensitivity troponins?
I talked a few minutes ago about how often you sample the troponin with the implicit understanding that you're looking for a sudden rise and then a sudden fall. But that is the classic example of an acute coronary syndrome or maybe Takotsubo's syndrome. However, most of the patients that you will see with quote unquote abnormal troponins, the majority of the time it's a abnormal level. It's probably not very high. And often when you do the serial measurements, it's somewhat flat. For example, the first value, just for argument's sake, don't ask me about the units, but let's say the first value is 85. The next value is like 92. The next value is 79. I mean, it's obvious that there wasn't a cataclysmic sudden insult to the heart. This is speaking to a low-grade kind of continuous insult to the heart. So the pattern of the troponin being more or less flat as opposed to suddenly increasing and then decreasing tells you that this is likely to be a type 2 or demand ischemia or a non-coronary type of insufficiency event.
Excellent. So the shape of that trend can really tell us a lot about the etiology of those elevated troponins. So if we peak and there is a sudden fall after that, we're thinking probably an acute coronary event in the spirit of ACS. But if we're looking at those adynamics and what hovering elevated troponins, then that may be more like type 2 NSTEMI. I know that there's always been this question of what's the delta, what makes a meaningful change, but I think the numbers that you just posed out, hypothetical though they may be, and certainly we won't get into units, kind of paints a picture. You can tell if there is a significant change between numbers or not. For those of us who really cling to numbers, I did find the European Society of Cardiology said that a significant delta is an increase of greater than or equal to 20% of the first troponin that was elevated, or an increase of greater than or equal to 50% of the initial troponin if the initial troponin elevation was just small. So just for the numbers folks around us, those are some numbers to go by. But I think, again, as you're saying, it really comes down to what's the general sense of what's going on here. Let's dip a little bit into some of those scenarios where a patient might have chronically elevated troponins. Can you give us a few scenarios of patients who might have chronically elevated troponins?
We now know very well who amongst our patients is a typical chronic elevated troponin patient. So first and foremost, the CKD and end-stage renal disease patients. Some of them do, and some of them don't have chronically elevated troponins. And you don't want to be in that group, even if it's low, but still it's abnormal. That group as a whole has more morbidity and mortality than the CKD and ESRD patients whose troponin still is below the cutoff. Another very large group now is the heart failure group. Everyone on this audio probably knows, of course, they're going to be measuring brain natriuretic peptide and then terminal proBNP for heart failure patients. But believe it or not, a certain fraction of those heart failure patients, especially the ones who are chronically volume overloaded and maybe miss their doses of diuretic and don't keep themselves tuned up, they will have low but persistent elevations in their troponin because, after all, they have a lot of stress on their endocardium from their very high filling pressures. So those are two groups that you need to keep a lookout for. In the setting of acute sepsis, there are a few patients where the sepsis itself releases, certain chemicals and acute phase reactants that actually have a myocardial depressing effect. And it's possible sometimes for you to see low-grade elevations in sepsis of troponins. But the heart failure group and the end-stage renal disease group are the two biggies. The group actually that has an acute PE, those will be a group that behaves more like a sudden insult with a peaking and then a trough. Eventually, if you do thrombectomy or if you just give heparin or lysis, when the thrombus recanalizes, that right ventricle usually settles down and the troponin goes away.
Right. These are some important phenotypes of troponin elevations, especially speaks to my heart as a hospitalist talking about our CKD patients and our CHF patients who will probably have those chronic elevations in their troponin. So something we can always keep in the back of our mind. And with that, let's do some spaced repetition to close part one of this series and leave our listeners with some key takeaways. So in the beginning, Dr. Cohen and I reviewed myocardial injury, which is a broad term that encompasses troponin elevations. Within that, we found the subset of acute coronary syndrome, which is a type of myocardial injury that results from a sudden or acute decrease in blood flow to the heart. We briefly touched on NSTEMI and STEMI, but Dr. Cohen importantly pointed out the different types of pathophysiologies that can lead to elevations in troponins, and specifically how that defines two types of NSTEMI. Type 1 NSTEMI can result from an acute atherothrombotic event, while type 2 NSTEMI results from a mismatch of myocardial oxygen supply and demand. Dr. Cohen also gave us several clinical features to focus on when we encounter a patient with an NSTEMI. Most importantly, he told us focus on the big picture. What do we think is going on as the driving factor for a patient's presentation, and how does that relate to their troponin elevation? We also touched on chest discomfort and some accompanying or related symptoms that we can find in a patient experiencing acute issues of the heart. We talked some about our diagnostic workup. There's some benefits to our EKGs, but they can also prove to be a little bit non-specific and not necessarily as sensitive as we would hope, but there is a tremendous value in getting a bedside ultrasound or echocardiogram. Finally, we delved into our serologic workup, which is, of course, our high sensitivity troponins. We talked about how this newer generation of troponins can be trended much more rapidly than our older troponins. And Dr. Cohen recommends checking after the first 1 hour of a patient's presentation to check and see if that troponin is continuing to trend up. We discussed a few morphologies of a patient's troponin trend, including the sudden rise and then fall that you can see in acute coronary syndrome, and of course, even in some related cases like a pulmonary embolism. And then we talked a little bit about some chronically elevated or adynamic troponins that you can see more likely in a type 2 NSTEMI in the acute setting. And then we talked about chronic conditions like CKD and CHF that can also leave you with an elevated troponin.
The opinions expressed are those of the reviewers, authors, and commentators and do not necessarily represent the views of Oakstone Publishing. Please review the complete prescribing information of specific drugs or combinations of drugs, including indications, contraindications, warnings, and adverse effects before administering pharmacologic therapy. Thanks for listening to CMEssentials in Hospital Medicine. To learn more, visit oakstone.com.